Good afternoon, ladies and gentlemen. First of all, thank you, Ashish, and other members of the organizing committee for inviting me here. It's an honor to be here at this podium. I've been asked to speak on partial knee replacement and its indications and a few tips on surgery. Osteoarthrosis of knee, as Dr. R.N. Singh just now said, is extremely common in our country, and varus deformity is the predominant deformity that we face. But are all varus knee the same? Do we treat all varus knee the same way? Do we do the same operation for all varus knee, those who need surgery? That is a question to be answered. And this publication in 2016 and even before gave us a new classification of varus knee, in which they have divided this into intra-articular deformities, metaphyseal and diaphyseal. So we now have started thinking differently about different types of varus knee, and that's how we will design the treatment for those knees. In the intra-articular deformity type, there is the anteromedial osteoarthrosis, in which this is a correctable deformity. The anterior cruciate ligament is intact. The disease is bone and bone. As time goes on, anterior cruciate ligament degenerates, the biomechanics change, and the disease starts going over to the posterior part of the medial condyle as well. And then it changes into posteromedial OA. And then there is a third type, which is a fixed deformity with lateral laxity, and the fourth one, fixed varus with no lateral laxity. So these four are different type of varus, and they need different treatment. As I said, and even John Goodfellow, many years ago in his team, in fact John Goodfellow was my examiner in England, and he brought up this concept of the anteromedial OA. Like here, those who do knee replacement, if you open the knee, many a time you'll find the ACL is intact, and the defect really is only in the anteromedial part of the tibial condyle, sometimes into the middle part, and other times it goes right down to the posterior, as we see in the third. Do we have a pointer here? Okay. Now you see the defect is here. This is up to middle and going posteriorly. But as you see in all these three pictures, there is this posterior cartilage which is intact, and there is this normal cartilage bump which is present here. Now this is extremely important, as we will see, because here you see on the X-ray there is the defect here, but this particular thing posteriorly is intact. If you see the pictorial representation of this, there is cartilage loss here, there is cartilage loss here, but this cartilage and this cartilage is intact. Now, when the patient is in extension, when the knee is in extension, the medial collateral ligament is lax because this is sitting in a defect. But when the patient flexes the knee, this normal cartilage rides over this normal cartilage bump, and it tightens up this medial collateral ligament. So when the ACL is intact, when this posterior cartilage is intact and patient is bending the knee, this medial collateral ligament never had a chance to contract. It regained its length, and that is extremely important in deciding the treatment. You see, when the patient sits, this is varus in standing. When the patient sits, this varus disappears as this femur rides over this bump. So this is a different ball game altogether. Now this will be possible only if the ACL is intact. If the ACL ruptures, in that case this type of movement is not possible. This cartilage also disappears, and this ligament remains short and ultimately becomes fixed. So once it becomes fixed, then it is not anteromedial OA at all. Then it's a posteromedial osteoarthrosis. The treatment for these two things is entirely different. So I just want to summarize till now what I have said is that anteromedial osteoarthrosis is a definite entity. This is an entity when ACL is intact. This is an entity when posterior cartilage is intact. This is an entity in which medial collateral ligament never had a chance to shorten and become fixed. So this is different from other types of varus knees. Even in extreme cases like this, when you can see there is so much of this involvement, if the ACL is intact, with this much of varus, this is still anteromedial OA. But these conditions must be met. And what are these conditions? That the medial OA must be bone on bone. The anterior cruciate ligament and medial collateral ligament must be functionally normal. I will come to this term functionally in my later slide. And the lateral compartment must regain its normal cartilage thickness. If these three conditions are met, then we can actually do only partial or half knee. There is no need to do a total knee replacement. And if these three conditions are met and we do a partial knee arthroplasty, the results are really, really fantastic. So how do we make sure that we are choosing correct patient for doing partial knee replacement? First is bone on bone. How do we make sure that it's bone on bone? Do a standing X-ray and it should be bone on bone as seen on this. If we don't see this bone on bone on standing X-ray, at least we should see this on varus stress X-ray. If we don't see that even on varus stress X-ray, we should not be doing partial knee. If the cartilage on the medial side is intact, we should not be doing partial knee because the source of pain may be something different. Even arthroscopy etc. is no good to decide this. It's the X-ray which has to tell us whether we are dealing with this type of arthritis or not. So how do we decide whether anterior cruciate ligament is intact or not? Only on X-ray. There is no need to do arthroscopy. There is no need to do MRI. In fact, these two things are misleading. It's only plain X-ray and clinical examination that will decide whether ACL is intact or not. How? We need a very good lateral film, and on that lateral film you see where is the sclerosis or defect. If it is finishing here, or if it is finishing here before the posterior part, you will find the ACL will be intact. If however the defect reaches posteriorly, or the sclerosis reaches posteriorly, or it has become slanting posteriorly, this is an ACL deficient knee. An ACL functionally intact. We don't want to see at a normal ACL of a 16-year-old boy. We don't need that for this kind of arthroplasty. So how do we decide whether the medial collateral ligament is functionally intact? By doing valgus stress X-ray, and if it opens up nicely and doesn't over open up, it is intact. How do we decide that lateral cartilage is intact in the lateral compartment? Again, do valgus stress X-ray, and if this joint does not collapse, the cartilage is intact. So by doing these tests, by clinical and radiological examination, we now have determined that this patient has anterior or middle part defect, has intact medial collateral ligament, has intact ACL, and the lateral compartment is good. So then I decide, well, why not go for partial knee? There is no need to do total knee arthroplasty. But for doing this, we need to do these X-rays very carefully. Initial 50-60 cases, we must do it ourselves and teach to our radiographer how to do them. Little flexion, 20-degree flexion, X-ray tube pointed 10 degrees, and then you apply stress varus or valgus. The patella should be right in the center to have a good X-ray, and then only we can say that this is a good stress X-ray and take a decision based on that. What about patellofemoral joint? In all these cases, we must do skyline view. If there is OA of the medial patellofemoral joint, it doesn't matter, because once we do the partial knee arthroplasty, the femur rotates externally a little bit, the patellofemoral joint is offloaded, and also now with the new anti-impingement jig, which you will see, the patella is totally off the prosthesis and it doesn't matter. However, lateral patellofemoral OA is a contraindication. Significant lateral patellofemoral OA is contraindication. So, having seen this, we have to be again careful that clinically ACL may appear to be intact when it is torn if there is a large osteophyte. It may appear to be torn when it is not torn if there is a large defect. MRI is usually misleading because MRI will always show some mucoid edema, some mucoid change, this and that, not important. Arthroscopy is misleading on the lateral joint because often in the medial part of the lateral condyle there is some little ulcer which doesn't matter. That was due to the impingement of the tibial spine, and once uni knee is done, joint opens up, it doesn't come in contact, so it can be done. So clinical and radial X-ray wise is the most important, and then of course seeing is believing. All these things must be checked once we open the knee. We must check the ACL with the hook and see that it is functionally intact, because many times you will find that the synovium may be eroded a bit, there may be some longitudinal splits, so these are grade 1, 2, 3. These are fine for doing uni knee. If however it is absolutely fibril or absent, that's a contraindication clinically. Similarly, we must check the lateral joint, must check the lateral joint cartilage. After having checked all these things, when we can proceed with the uni knee. Every time we take a patient for uni knee, there is a backup available for total knee. If we find that these conditions were not met, we will simply switch over to total knee. But it happens very, very rarely. Actually, it has never happened to me if you are careful. So, the posteromedial OA, as I said, is a contraindication, not suitable. Metaphyseal deformity, not suitable. Previous HTOs, not suitable. Diaphyseal deformities, not suitable for unicondylar knees. What is now suitable is SONC, or osteoidiopathic osteonecrosis. We can go ahead and do uni. In this, we don't even need a bone on bone. Once we diagnose SONC, it can be done. And lateral joint OA can also be done with uni, but be careful that we cannot do it with a mobile, because lateral meniscus is very mobile. Lateral collateral ligament is far away from the joint. On the medial side, the medial collateral ligament is hugging the bone. It stops the meniscus from dislocating. On the lateral side, the chances of dislocation are higher. Therefore, if we have to do a lateral unicondylar replacement, we would prefer to do a fixed type of unicondylar rather than mobile one. So, rheumatoid arthritis and inflammatory arthritis are also contraindication to unicondylar arthroplasty, because in that the bone is very weak and it will collapse, and it's a global involvement. Again, we keep emphasizing on these things, and I'm going to repeat it again for emphasizing it. Full thickness medial cartilage loss, bone on bone, lateral compartment okay, ACL okay, medial collateral ligament okay, go ahead with unicondylar knee arthroplasty. Now, the beauty of unicondylar is that because we are not touching the posterior capsule, even if some flexion deformity is left, there is a chance for this to stretch and that deformity will correct in a year. Whereas in total knee, we are already distracting the joint. Whatever flexion deformity you leave, say about more than 5 or maximum 10, it is not going to correct. Similarly, in total knee arthroplasty, we have to do a lot of releases. In unicondylar, no release at all. If you even accidentally release a ligament, abandon the unicondylar arthroplasty. We depend on intact ligaments. So no releases at all in unicondylar. Whereas in total knee arthroplasty, we are so finicky about getting the alignment right, that in fact I do all my total knees with navigation, all 100%, and Dr. Ashish will also show you with navigation, because we want to get the alignment right. It's so important. If the alignment is not right, it's going to fail. That is not the case in unicondylar, because in this the alignment does not depend on the way we put the implant. The alignment depends on the thickness of the meniscus that we put in. And because femoral component is part of a sphere, even if alignment is 10 degree here and there, it doesn't matter, because it is still going to move in a sphere. So important thing is to get the flexion and extension balance right. Rest is all very forgiving in this. The idea is that we must cut as little of tibia as possible. We want to use the strong subchondral bone. The biggest mistake people make is cut too much of tibia, and then the tibia fails, there are tibial fracture. Cut as little as possible, and then it will be a success. Then there are different now very beautiful instruments available, spoons to tell us the size, the G clamp to tell us how much bone we need to cut, whether 3 or 4 millimeter, and we need to make sure that we go as close to ACL as possible when we are making that vertical cut. In fact, take a few fibers of ACL off, doesn't matter. ACL is a big thick structure, it doesn't matter. So go as lateral as possible, so that take as much advantage of the bone available as possible, so that the tibia will not fail. And when we are cutting the tibia with the vertical saw, our hand should point down. We never want to cut the posterior cortex, because that's a weak point and we don't want to cause a fracture. Similarly, medial-lateral position, as I said, go as lateral as possible so that it doesn't have a chance to dislocate. Now you see here, when we open the femoral canal, normally on total knee we would open here, but in this we open it a little more medial, because we don't want it to impinge with the future, the patella there. So we want to stay away from that area. And once we've done that, then these instruments are available, connectors, and we want to make sure that we put it right in the middle of this. This is how it appears operatively. This is how there is a jig to cut the posterior part of the femur. Again, we put our hand down so that we cut proper portion, and these are the new microplasty instruments, beautiful instrument. It just cuts it and with a rotating movement, and then we test it with just 2-finger test. And balancing of the flexion and extension gap is extremely important. We determine the flexion gap and then make the extension gap according to what flexion gap we have achieved. This is a complicated thing, I will not go into here, but important thing is that when we judge the space, the spoon should just go with 2 fingers, with just very little pressure. And once we have done that, then of course we do anti-impingement and do the final trial. Now these are some of the case examples. You can see the bilateral unicondylar knee orthoplasty, bilateral medial OA, bilateral unis, and here I'll just give you an example of some of the patients. I hope this will work here. This is just 10 days post-op, bilateral uni.
तो आपके दोनों घुटने में काफी दर्द था?
हाँ, दोनों घुटनों में मेरे काफी दर्द था।
तो अभी आपके ऑपरेशन तो हमने दोनों घुटने का
चेंज किया
है ना, तो उसको कितने दिन हो गए हैं?
10 डेज हो गए।
10 डेज हो गए। तो आज ही आपके स्टिचेस निकले?
जी जी।
तो आप खुश हैं?
जी।
अच्छा, जरा चल के दिखाएं तो। ये कपड़ा नीचे कर लो, नीचे।
This is bilateral uni, 10 days post-op. Okay? And now this is another one. This is 6 weeks post-op.
दोनों घुटने का partial या half knee replacement.
I'll take 1 more minute.
2 months back. तो उससे पहले कितनी दर्द थी आपको?
काफी दर्द था और ऐसे लगता था कि मेरे से कोई सब कुछ ले ले और मेरा दर्द ठीक कर दे।
तो फिर ऑपरेशन के बाद कैसा लग रहा है?
एक्सीलेंट लग रहा है, कोई प्रॉब्लम नहीं है। आई एम वेरी हैप्पी।
तो पूरा चलते फिरते हैं आप?
हाँ जी, बिल्कुल चलते।
कोई दिक्कत चलने में?
नहीं, कुछ नहीं।
और आप
स्टेयर्स भी मैं चढ़ लेते हैं।
स्टेयर भी चढ़ लेते हैं आप अपने इंडिपेंडेंटली चलते हैं? जरा आप जरा चल के दिखाएं तो। वेरी गुड, पीछे घूम जाइए।
This is just to show you they can do the stairs and they can how they sit.
जरा चल के दिखाओ और जरा बैठ के दिखा दीजिए। क्रॉस लेग करके बैठ जाओगे?
हाँ जी।
करिए, बैठ जाइए।
Here, we allow them to sit cross-legged because it's a unicondylar knee orthoplasty. There's no problem. They can sit cross-legged. Now, these are other examples. This is 6 months later.
पार्शियल नी रिप्लेसमेंट हुए दोनों, उसको कितने महीने हो गए?
He plays golf. He plays light tennis.
वापस
So everything's done. Now, these are. You can also do 1 uni and 1 total if the situation demand, like in this case. And we make them stand sometimes the same evening, sometimes next morning, and they go home in 3 to 4 days for unilateral and 5 to 6 days in bilateral. These are some of the results from Oxford group, and this is our experience also. The results are all in favor of uni, and the chances of readmission and reoperations are much less with uni, and the Oxford score also is great with the uni. Some people, those who don't do condylar knee arthroplasty, if a unicondylar arthroplasty patient comes with a little pain, they have a very low threshold to revise it. That is not correct, because if you go through the literature, actually speaking, all these last for 15 to 20 years. So unicondylar gives us high flexion, gait is almost normal, stair negotiation is better, the morbidity is obviously very less, the DVT chances are very less. Now we are doing all this without tourniquet and is unequivocally safer than total knee. Previously, this study was quoted that the obese patient should not have uni, extreme age patient should not have uni, chondrocalcinosis should not have uni. But with this mobile, all these contraindications have gone to the bucket. On this Monday, I'm going to do a uni in a 130 kg patient as we speak. And we have done many in obese. For example, this patient is 103 kilos, short patient, and we have done uni for her, and she's done great. So just to summarize, unicondylar is a great concept which was brought in about 2 decades ago, but somehow did not catch the imagination at that time because the instrumentation was a little complex and we did not understand anteromedial OA properly. Now we have a proper understanding of that OA. The instrumentation is now great with the microplasty instrumentation, and once we are able to diagnose it properly by saying that okay, it's bone on bone OA, lateral compartment is okay, ACL is okay, and medial collateral ligament is okay, doesn't matter what age, doesn't matter what weight, that's a great indication for unicondylar arthroplasty, and the results are excellent in these cases, I can assure you. Ladies and gentlemen, I thank you for your attention.